A typical operating room setup for arthroscopy would include 1 or 2 monitors. For shoulder arthroscopy, 1 monitor may be at the foot of the bed and 1 directly across the patient from the surgeon. We would have the tower or boom with all the control units and fluid pump across from the surgeon as well. At the head of the bed, we have our anesthesia cart. Most operating rooms use a pump system for pumping saline. You can also hang bags from an IV pole and use gravity. Raising the bags higher increases the pressure of the fluid seen at the joint. You may hang 2 to 4 bags at a time. Typically 2 bags are attached to the tubing. The gravity system tends not to distend the knee or shoulder as much as the pump system. Here you can see our standard setup for knee arthroscopy. First we're going to place the stockinette over the thigh all the way up to the groin. You can also use cotton roll or web roll. Then we'll place our tourniquet in place. The web roll is to decrease any type of irritation on the skin or pressure. We'll cinch that down tightly right at the groin, taking care to protect the genitalia. We'll then tie our tourniquet. We'll roll the stockinette over the end of the tourniquet, and it does help to pull some of the thigh tissue down underneath the tourniquet distally. That stops the tourniquet from sliding as much. Then we'll place our foam pad on the thigh. This is the cushion that protects it in the leg holder. We then have our metal leg holder. We like to get this as far down at the bend of the bed as possible, so that when we drop the legs, we have a good length of the thigh still protruding from the leg holder. Next, we're going to place a protective pad under the non-operative leg, taking care to protect it from the metal bars on the table, and also make sure there's no tension on the perineal nerve. We then prep the leg using ChloraPrep or DuraPrep all the way down to the ankle. We make sure that we get it underneath the knee as well, and then come back up and get the area right alongside the leg holder. We then apply our sterile U-drape. You could have placed a non-sterile U-drape first if you prefer, prior to prepping. Next we'll place our impervious stockinette. Then we'll apply the Coban to hold this in place. Again, you want to roll this out rather than stretch it too tightly. And go right up to the top of the stockinette. Next we have our arthroscopy drape with the pouch. We bring the foot through the extremity hole, slide this up over the knee, and then place our sterile drape over the patient. We leave the pouch up at the top at this point until after we exsanguinate the leg with the Esmark. Timeout was performed. The mark preoperatively is noted. The patient was given the preoperative antibiotics, and everyone agrees that we have the correct operative leg. We then use the Esmark to exsanguinate the leg, and then we can inflate the tourniquet to either 280 to 300 millimeters of mercury. We then remove the Esmark and we're ready to start our procedure. The patient is intubated and put to sleep. You can see we have the safety belt in place during this time. The safety belt is then loosened in preparation for turning the patient. We'll pre-place some of our foam pads along the lateral aspect of the knee near the peroneal nerve and also along the lateral malleolus. Now we'll get ready to move the patient and place her in the lateral decubitus position. Anesthesia is responsible for the tube and the patient's head. We then move the patient halfway across the table and then roll the patient into the lateral decubitus position. We then lift the chest and place the axillary roll, leaving 2 finger breaths below the axilla so there's no compression. We can then bring the beanbag up into position, and before inflating, we'll then put a pillow between the knees and again protect any of the bony prominences. We like the patient to be leaning back about 10 degrees when we apply suction to the VacuPak. You want a large beanbag to control the body, but at the same time you don't want to block yourself out from being able to make your anterior and posterior portals. We do like the 10-degree posterior tilt, so that places the glenoid level with the floor. We then close the valve for the beanbag. We once again verify that all the prominences are padded, that we have the pads underneath the peroneal nerve, the lateral malleolus, we have the pillow between the knees, and then we have the axillary roll in the proper position. We then bring up our blankets, try to keep the patient warm during the procedure. You can also use a bear hugger to try to maintain body temperature. We then place the safety strap back in position. We start with our non-sterile U-drape, placing it in a position that is very wide and not draping ourselves out. We want to make sure that we have enough room to reach our portals. Placing this non-sterile drape in position then shows the assistant exactly where to prep. Checking motion and stability can now be assessed, and if manipulation is needed, it can be performed. The frame for the overhead traction is then applied to the bed. We like this at the very foot of the bed. We typically like the frame about 10 degrees anterior and about a 45-degree angle from horizontal. We want to make sure that the length of the traction line is adequate and that you can reach the arm. We then prep the arm using a ChloraPrep or a DuraPrep. We prep all the way up to the wrist. We make sure we get around the edge of the drape, and the arm is held in a position so that the top part of the shoulder and neck does not come in contact with the non-sterile drape. We can then put our first sterile U-drape, and we come just over the non-sterile drape, again trying to maintain as much area for an operative site as needed. Next, I like to apply the traction sleeve. This is a stockinette with a loop at the end to apply to the traction. Once this is rolled down past the elbow, we go from the wrist all the way up to the top of the sleeve just above the elbow with the Coban. We don't want to make this too tight or it can compress the ulnar nerve at the elbow. If you make it too loose, the sleeve can slide off. Now we can suspend the arm from traction and then continue with our draping. We now apply our sterile U-drape at the top of the shoulder. This covers the head and then extends inferiorly along the anterior aspect of the chest. We push it down in the area of the clavicle, supraclavicularly, because that's an area where it tends to leak. We then apply our sterile bottom drape, which again is a split drape, each time adhering to the skin just slightly tighter than the previous drape. And the final drape comes in from superior, and this has our pouch for the arthroscopy drainage. Here you can see it's a clear, sticky drape. This you can put up a little further on the skin, again making sure that it's pressed firmly against the skin to prevent leakage down along the neck. This top drape is then raised up along the edge of the IV poles in order to protect anesthesia and also to improve our sterile field. Our Mayo stands are then brought into place with our arthroscopy equipment and our cannulas. Here we have our standard beach chair positioner. You have the headrest, which the patient's head will be strapped to the headrest, and the patient should be high enough up on the table so that when the beach chair is raised, the patient will flex at the waist and not slide down the table. We have a side pad that keeps the patient on the table and limits the amount of tension on the neck when pulling on the arm. It's very important to keep the head lined up with the rest of the body. There is a movable center section which allows better access for the posterior portal during arthroscopy. Once the patient is intubated, the protective head straps are then placed with foam padding in order to protect the head. You can see that we also have eye protection in place as well. It's important to have the endotracheal tube going to the opposite side from the operation. Again, we check to make sure that there's no undue tension, that the pad is holding well, that the eyes are well protected, and that we have adequate exposure to perform our arthroscopy. We make sure that our side positioner is fastened well, holding the patient snugly on the table. We again make sure that there's no tension on the neck, which would increase the risk to the brachial plexus. Next, we'll apply our non-sterile U-drape, which will delineate the scope of our operative field. Again, give yourself plenty of room, making sure not to drape yourself out and make it difficult to reach the arthroscopy portals. We want to make sure that we have good access to the anterior aspect of the shoulder, the posterior aspect, the lateral aspect, and the supraclavicular region. Now we'll prep the arm with ChloraPrep, covering the entire area from the exposed neck all the way down to the wrist. We then place our sterile U-drape just over the initial drape. Then we'll place our superior drape. Now we can bring in our stockinette. We'll take the hand, place our traction stockinette over the hand and down past the elbow. Now we'll wrap it with Coban, taking care not to stretch it too much and make it excessively tight, which could cause compression of the ulnar nerve at the elbow. On the other hand, you don't want to make it too loose where it could slide off. But it's best usually to roll this rather than stretch it. Now we have a beach chair drape which has an arthroscopy pouch. And this stretches directly over the shoulder. And then we can lay the arm to the side. There are also variations in the drape, including a U-drape with an up and down U-drape and a pouch. And you can also use a spider to control the arm. You can then bring in your arthroscopy trays and you're ready to start.